So we are now moving to the two short talks that of the session before the end of the session. So the first talk will be by Dr. Jamie Either. So Jamie is working, well, he has been working on AIRRC5 since many years now, developing data analysis tools, especially in Benny Chain's lab, and also exploring the immunopeptidome and TCR repertoires in cancer. He is now rather developing immunotherapies, if I got it correct, against ALK positive lung cancer. And today is going to introduce his work on TCR repertoire as a marker of the impact of radiotherapy protocols. So it's your turn, Jamie.
Well, thank you for the kind introduction and to the organisers for inviting me. Can everyone hear me and see the slides?
Not yet.
Okay. Oh, I'll share the screen. That'll help.
Yeah.
How about now? Okay, great. So the previous two speakers have, oh, my slides not. The previous two speakers have talked about the remarkable success that immune checkpoint blockade has been having. So that's kind of cemented our seat at the table for immunologists in the world of cancer therapy and cancer research. And that's joining kind of longer standing cornerstone therapies like radiotherapy and chemotherapy. And as has been mentioned, one of the major goals now is to try and explore different combinations of these therapies to see if we can get the best response in the most patients. And this slide here just shows of combination trials started in the last 2 years that are targeting the PD-1 axis, which other modalities they're being trialed with. And you can see that radiotherapy accounts for a significant fraction of those. And this is not surprising, given that in the course of cancer treatment, over half of patients will receive radiotherapy in one form or another. And there's kind of two main flavors of radiotherapy. There is the kind of conventional radiotherapy, which relies on photon-based irradiation, which has a particular property in that there is a non-insignificant deposition of energy both before and after the target. So you can get around this with using lots of different angles, but that is something that happens. And this is the form of therapy that 99% of radiation therapy patients receive. However, in more recent decades, there's been the advent of proton-based radiotherapy, in which one is able to much more concisely, much more accurately contain the dose deposition to a particular 3D space. And this is relevant to immunologists as, while generally radiation therapy is known to induce a typically transient lymphopenia, it tends to be much worse in photon-treated patients than proton-treated patients. So this data here is from a couple of hundred patients that were treated for GI cancers at MGH Radio-Oncology department. And you can see on the left in blue, patients who receive photons, their absolute lymphocyte count at their nadir at its lowest point in the course of treatment is substantially lower than that in patients who receive photons. And this corresponds to a much higher grade lymphopenia. So we wanted to try and explore this and see whether or not the lymphopenias incurred by these two treatment modalities differ qualitatively or quantitatively. And also just to somewhat bridge that gap, radio-oncologists and immunologists are not typically people that work together very closely, despite the fact that both fields probably have a lot to offer one to the other. So we made use of a bank of prospectively longitudinally banked samples that had been collected. So these are all GI cancer patients who received either photon or proton radiotherapy, and for whom we have banked blood samples at 3 different time points. Time point 1 at baseline, when they were receiving their radiotherapy, time point 2 at the nadir of their ALC, and time point 3 when their lymphocyte counts were back up to some stable plateau. And so all 20 patients, all 3 time points had TCR sequencing done with adaptive, and 14 of the 20 also had enough blood left over for flow cytometry. And this kind of has all the typical failings of a small retrospective cohort study, or the limitations rather, and one is that we're both poorly powered and poorly controlled. So particularly with respect to which tumor types had which treatment types. So on the left here, you can see we don't have great division of tumor types between the treatment types. So this is kind of informed by clinical practice. And on the right, we can see our proton-treated patients tended to be a bit older. But if we look at the raw ALC values on the left from the clinical data, we can see they both start and finish at the baseline and recovery time points are the same between the two treatment modalities. However, the photon-treated patients plunge much lower and rebound back up more. We can look at the CD3 staining in the flow and see that, again, the photons corresponding with this greater plunge, their T cell levels seem to more significantly be affected and not rebound quite so well. You can also look at different subpopulations that you might think would be of relevance to mounting a anti-cancer immune response. We can see that the photon-treated patients at baseline prior to radiation have a higher naive CD4 T cell population, probably as a consequence of being somewhat younger. And this is lost in the course of treatment and does not recover. And similarly, at the end of treatment, the photon-treated patients have a large Treg population accumulating in the blood, which may hinder an anti-cancer immune response. And then we can also look in the TCR data. So this is all just gDNA TCR beta data from 1.5 mil of whole blood. We can see, just looking at the total TCRs on the left, the proton-treated patients in orange are pretty stable, pretty consistent in spite of their lymphopenia, whereas the photon-treated patients have this rebound, this decrease in rebound. But if we look in the unique TCRs, ignoring their read abundances, we can see there is no rebound. So already, by comparing these two violins, we know that something is amiss, that there's some clonality changes going on. So you can plug that into whatever your favorite clonality or diversity metric is. I'm quite partial to the Gini index. So this is bounded, 0 here would be total equality, all TCRs being equally prevalent. And as it tends towards 1, a smaller proportion of the repertoire would be taking up more of the space. We can see there's no real difference between the baseline and nadir time points, but in the recovery time point, there's a big shift upwards in Gini index in the photon-treated patients. So this is kind of akin to a big increase in oligoclonality. And we can plot the change in Gini index between the time points and plot that on the XY here to look at specific patients. We can see the orange proton-treated patients kind of cluster a bit more around 0, whereas there's this expansion in Gini in the blue photon-treated patients following on from the nadir. And we can look at other TCR metrics like sharing of TCR retention between time points. This is just by a Jacquard index. So we can see that the blue photon-treated patients share far fewer TCRs between their samples than do orange proton-treated patients. And we can also correlate the two different modalities. We can correlate the cytometric and the repertoire parameters. So it's a slightly busy slide, but we have the Gini index on the y-axis. We have proportion of a CD8 T cell subpopulation on the x, with naive cells at the top and Temra, terminally differentiated effector memories on the bottom, and the time points, the columns. And the thing I want to draw your attention to is that in the first 2 time points, it's very similar. Roughly, it's what we expect. The more naive CD8s you have, the more evenly distributed, the lower the Gini index you have. Conversely, for the Temras, the more Temras you have, the higher your Gini index, the more unevenly distributed, as this is a very oligoclonal expanded population. But we can see that the gradients of these lines differ, and that is probably reflective of the increased age of the proton-treated patients. However, following the recovery, following the nadir into the recovery, we can see that these gradients now basically overlap. It's kind of like the photon treatment is immunologically aging the photon-treated patients. And we also can look at clinical measures. Unfortunately, we're not really powered to do this very much. So if we kind of disregard treatment type for the minute and just look at all patients, on the x-axis here, I'm plotting the change in Gini index between time points, and on the y, I'm plotting the time to last follow-up from the recovery bleed. And all but 2 of the patients had sadly died at this time, at the time of data collection. But we can see that in the first transition, baseline to nadir, there's no real relationship, just looking at the purple dots. But in any of the transitions to the recovery time point, we can see there is an inverse correlation, effectively meaning if you have this big increase in oligoclonality post into your recovery time point, then you're more likely to pass away sooner from following your radiation-induced lymphopenia. So to summarize, the photon-based radiation therapy seems to be inducing a much more profound T cell compartment remodeling then is seen with proton-treated patients who seem to basically kind of just soldier on with their repertoire intact. And many of the changes that are brought about in these photon-treated patients bring their distributions into line of those that received protons who were themselves much older. So this raises the possibility that perhaps proton-based therapies or perhaps other lymphocyte-sparing radiation regimes may better synergize with immunotherapies, or may themselves just be better overall. In fact, I didn't show the data, but there are data showing that radiation-induced lymphopenia generally correlates with poorer survival. And I'd like to thank the other people that did all the work, and thank you all for your attention. I think I'm perfectly on time.
Thank you very much, Jamie. I have several questions actually. When you looked at the proportion of the different cells in the blood in your different treatments, so there was definitely a difference, major difference in terms of Tregs in the photon treated patient compared to the proton. And actually, although at baseline or at the first time point, it was not really different, but quite soon, Tregs tend to be a bit more present in one therapy compared to the other. So is this related to the efficacy of the therapy? Again, so Tregs are usually a bad prognostic in cancer because they are immunosuppressive, and so do you have any?
Absolutely, it could well be. Unfortunately, we don't have any clinical metrics by which to test that. But certainly, I mean, the reason people are trying radiation therapy with checkpoint blockade and stuff is because a lot of the things that that photon-based irradiation does are potentially pro-immunogenic against the cancer. You know, it does make a lot of neoantigens and a lot of inflammatory cytokines and so on, but it does also do these things like increase Tregs. That was generally a known property. I don't know whether or not that is a function of successful treatment or you know, of off-target irradiation. There's also things like Tregs themselves are more radio stable in comparison to normal effector T cells, and also different tissue distributions and things like this. It's quite an interesting immunological question, actually, that the nature of what irradiating people is doing. Because also, you know, these are all GI cancers. We're hitting a bunch of different lymphoid tissues and vasculature, and like probably for a lot of them, thoracic duct. So exactly which T cells or which lymphocytes and which leukocytes are getting irradiated, how much and when, is quite a tough question to unravel.
And following question, you've been comparing systematically the repertoires between the different time points, but when you did some comparison, it was generally within each therapy. So I was wondering in your clonotype the clonotype expansion that you saw arising in your different protocols, did you check whether those expanded clonotypes were similar regardless of the therapy, or is there any difference?
Sure. We did look a bit. They weren't, but we don't have HLA typing information, but we've got no reason to believe that they are. There is significant HLA overlap in these patients. So nothing obvious leapt out. And, you know, I also tried to guess what they may be based on the CDR3s, but again, nothing obvious leapt out. So it's kind of almost that these more broad level metrics seem to be, have produced the most utility as opposed to some of the more refined granular analyses.
Well, there is no additional questions, so thank you very much.
Thank you.
And we'll move to the next speaker.